All right, there we go. Perfect. Well, welcome everyone. We're just going to get everyone to file in here, and then we'll get started in a few minutes with our class discussing the case we had this morning on advanced airway management with a COPD patient, which is a tricky patient to manage, which is why we want to talk about how aggressive you need to be with these patients. So hopefully you guys are excited about that. So go ahead and come on in. Good morning. Just making sure everyone has made it in here and is ready to go. Perfect. Welcome. Okay, so we're going to get started in a couple minutes here. I started a little early just so I can kind of come and say hi. But while we're waiting for everyone to show up and to kind of get settled in here, go ahead in the comments, throw in the comments where you are watching from. Okay, where in the world you are watching from. I always love to do this. I think it's fascinating. I know I say it every single time for those of you that have done this a lot. But I always love to hear where you guys are all from. So go ahead, put that in the comments. Where are you watching from? And we're going to get started in a few minutes as you all are filing in here. Where are you all? India, Iowa. Let's get you over to the page here. There we go. I just wanted to get it over to our Facebook group as well, so that way they can get everything as well. Make sure I don't bump everything. Okay. Oh, Beirut, Denver, Iowa, Israel. Love it. New York City. Fantastic. I love it. I think this is always fantastic to see where you guys are all from. All right, let's see where else. Iran, Angola, UAE, Saudi Arabia, Puerto Rico, New York, Oklahoma, all over the place. There you go. There's someone from Canada, my stomping grounds as well. So it's good to see too. So thank you for repping Canada there as well. So what we're talking about today is advanced airway management of a COPD patient. You'll notice that I'm doing things a little bit differently today, just because I want to try some things different and kind of give it a different feel by controlling it kind of in a more, moving around type of format. So hopefully you guys are looking forward to, getting a different feel of how we're going to present today's case with a different type of visual in order to, get things going and being a little bit more interesting. So let's talk about today's case now that it's 12 o'clock and you guys have got your coffee and your waters and you're all set to go. So let's first off, just while you guys are here, while you guys are settling, if you guys love the way that we do education, if you enjoy the way we explain things, draw things, illustrate things, one thing that we do offer is a premium membership for paramedic and EMT students. And so if you're struggling in school and you want to retain information better, you want to get those aha moments going more and more and more, that's what we do at Master Medics, is that we offer a EMT and paramedic student subscription in order to go through any course you can possibly think of that is in your textbook. We have a course for that. And so if you're struggling in school or you want to understand medicine even better, then you should check us out for a 3-day trial. See if it's for you. If it is, stay as long as you like. If it's not for you, you can cancel anytime, no hard feelings. And you can still enjoy all the live content that we do and all the free stuff. But that is your opportunity to cut your study time in half in order to get your life back and really enjoy the process of learning again. If you guys are through school already, we do offer continuing education as well. So make sure that you do check out our subscriptions for continuing education too. You get to use these cases for continued education. So you can use these cases for continued education. We do continued education different than anyone that you have ever seen. I know people say that all the time, but I'm going to prove it to you. So get into that subscription, check it out, and I'll prove to you that we make learning worth your time and continued education worth your time. So check that out as well. Okay, that's out of the way. So let's talk about this case. So you're dispatched to a 58-year-old male patient who's complaining of shortness of breath. You arrive on scene to find a well-known patient, so a patient that has frequently called EMS, and they often have breathing issues due to their COPD. The patient appears increasingly fatigued, agitated, and confused. And you start treatment using albuterol and have started CPAP. However, the patient continues to get weaker and more fatigued as seen in the video. And you can see the patient down here in the corner. Leaning over, tripod position, struggling, obviously fatigued. Okay, obviously fatigued. So based on this presentation and everything that you're seeing so far, what is your primary concern for this patient? What is your primary concern for this patient right now? Go ahead and put that in the comments. Airway compromise, advanced airway is your concern, ABCs. What else? What do you think? Respiratory failure, good. That's kind of where my thought process is as well. What else are you thinking? Oxygenation and ventilation. Respiratory failure. Good. You guys are all on the same track of what I'm thinking. I think that this person's primary concern is that they are going towards a respiratory failure. Now, we don't know if they're in respiratory failure yet, but they're looking that way. And it's all due to hypoxia. Okay, this patient is having ventilation problems that are now turning into hypoxic problems, and this person is continually spiraling down that route. Okay, so our primary concern with this patient is absolutely an oxygenation problem due to some sort of what we think ventilation issues. So let's take a look at the vital signs to see how this patient is doing after we've used albuterol, after we put on CPAP. So let's take a look here. Okay, so before we look at the vital signs, I did want to explain something to you as well. And the signs that we're seeing and the signs of hypoxia in itself are all really and truly all due to a patient that's kind of spiraling. Like I said, we think this patient is in respiratory failure. We're seeing those signs, and those signs that we're seeing that are kind of advanced hypoxia are, first off, the tachycardia is likely an advanced hypoxia due to advanced hypoxia. The fatigue and the confusion, the agitation, those neurological symptoms, those are all due to an advanced hypoxia that's now causing these types of symptoms. Not the only thing that can cause confusion and fatigue and agitation, but it's often a culprit when you have an advanced stage COPD patient that is now having trouble oxygenating their bodies. And then obviously low saturation too would be a sign of hypoxia and would confirm our suspicion that all of these this level of consciousness problems that we're having is due to that. Now, we did mention this patient is in some sort of respiratory compromise leading to respiratory failure. And in this patient, because we know that this is a COPD patient, we're assuming that we've done a full assessment and we've confirmed that that's the case. The issue that we're seeing here with COPD patients is actually truly not due to the alveoli. The alveoli itself really is unaffected particularly, or it's at least not the cause. It's going to start to be a problem down the road. But right now, the alveoli are not really the problem. Where the problem lies in a COPD patient is here, okay, within the bronchioles themselves. And so there's two different types of COPD that we can see that we're going to talk about today, and that is emphysema and chronic bronchitis. And regardless of which type they have, it's going to affect the bronchioles in a similar fashion in which they cannot move air appropriately. They cannot ventilate appropriately. And so what happens in these types of patients? In emphysema, it's all due to a destruction of elastin in the lining of the bronchioles, meaning they can't expand and contract their bronchioles, which means they have a real problem actually creating negative pressure to draw air in. And so that's why an emphysema patient struggles with those bronchioles. whereas a chronic bronchitis is actually a spasming and also a increased and excessive mucus production inside the bronchioles that creates a really wet, mucousy, clogged kind of pathway. And so we can't move air nearly as well through the bronchioles into the alveoli or out of the alveoli. So regardless of which COPD exacerbation we have, emphysema or chronic bronchitis, we know that it's the bronchioles themselves that are going to be affected. And the good news is that the treatment, regardless of the type of COPD they have, is pretty much the same, especially in the emergent setting. Okay, so that's what our patient's really struggling with. This is our primary problem, is hypoxia, and that hypoxia is due to a ventilation problem, and it's all due to damage and inability to move air through the bronchioles themselves, creating a hypoxic state in the end. Okay, so now that we know what the problem is and why this patient is having such an issue, let's take a look at the vital signs and see where they're at right now. Okay, so we have a patient that is a heart rate of 144, we have a blood pressure of 108 on 70, MAP 82 right now. EtCO2 is 79 with a respiratory rate of 18. Okay, and then we have a 88% on the saturations. Okay, 88% on the saturations, end-tidal CO2 79, even with a breathing rate of 18, and a heart rate of 144 and blood pressure of 108 on 70. So my question to you is, what is this patient's vitals suggesting to you? Okay, what are this patient's vitals suggesting to you? Okay, we know that they have a hypoxic problem. We know that they're probably leading to respiratory failure. And so do the vital signs confirm or negate those suggestions or concerns? Okay, are they really leading to this? Is this patient really sick based on the data? Go ahead and put that in the comments. Okay, saturation is an issue. Let's see what else you guys got. They're hypercapnic, very sick. EtCO2 79, they're absolutely in respiratory acidosis. They're hypoxic for sure, and they're very sick. Retaining a lot of CO2. Definitely supports failure, acidosis. I 100% agree with you. Let's just go back to the vital signs here. And so what people are saying right now, just to kind of recap some of the comments, is that this patient is absolutely hypoxic. In fact, they're severely hypoxic. And we know that based on the presentation of the patient, and then the SpO2 confirms that. That's what I like to use with vital signs, is that when your first impressions are going, oh, this patient's really sick, and then you put the vital sign, you put your SpO2 monitor on, you do vital signs on that patient, your vital signs confirm your suspicions. And that's exactly what happened here, is that this patient's altered, they're showing tripod positioning, they're confused, and then you put on the SpO2 and they're 84%, you go, okay, that checks out. Okay, that confirms your suspicion. That's what vital signs should do for you. And they should guide you in your suspicions and your diagnosis. Now, another thing that's mentioned is this patient is hypercapnic, and I agree with that as well. This patient is severely hypercapnic at 79. Okay, our normal ranges for EtCO2 are 35 to 45, and so this patient absolutely is hypercapnic. They're above our normal ranges, which means that they are holding on to CO2. Okay, it means that their lungs are not able to get it out. Okay, because that's the primary job of the lungs. Okay, with the exception of oxygenation, their other job is to get rid of CO2 or retain CO2. And in this particular case, they're retaining too much. And that is a clear-cut reason of that, is because they're not able to get it out. Okay, their ventilation is poor. Okay, the main reason that we can get CO2 out is because of good minute volumes. You and I right now, we're able to breathe no problem. We're able to ventilate no problem. We have good minute volumes. When a patient is having a COPD exacerbation and they're not able to ventilate, they're not able to keep up with good minute volumes, then they end up in a place that they're hypercapnic and they're not able to maintain acidosis, their pH. So this patient absolutely is leading towards respiratory failure if they're not already there as it is. Okay. So let's talk about what our treatment is. Now that we know the presentation of the patient, what that means, why that's a problem, and now we know that our vital signs have confirmed the suspicions that we have. Let's look at what we would do in the next 15 minutes. We know that we've done albuterol, okay, and probably a couple rounds of it. We know that we've done CPAP and we've started the CPAP, and this patient is still deteriorating. Those vital signs are from our patient after treatments. Okay, so from this point forward, we need to start thinking we need to be aggressive with this patient. So put it in the comments what you think you would like to do, or what treatments or what options we have at this particular point prior to intubation. Okay, because that's kind of where we're heading right now. We know that. But what are some things that we can do maybe to stave off the likelihood of intubation? Go ahead and put that in the comments. What can we do to try and avoid intubation? Mag sulfate, solumedrol, epi, okay. BiPAP, pursed lip breathing, epi. Okay, while you guys are doing that, and someone has mentioned that this is an absolute violation of HIPAA because we're using actual patient information. Just so you guys are aware, we actually produce patient scenarios, and this is actually me as a patient. So this is not a HIPAA, discrediting. Okay, this is not something that actually is disclosing of any patient information because the patient is fake. Okay, this is total patient scenario stuff with full-on moulage, but it actually makes me feel good to know that you guys were concerned about HIPAA because it means that our patient scenarios are realistic enough. So, but yes, this is a mock patient scenario. There is no giving up of HIPAA information. This is a fake scenario. Okay, so back to it. What treatments? Mag sulfate, albuterol, yeah. IM epi for impending respiratory failure, magnesium fault, along with inline neonebs. Yeah. Ketamine, dexamethasone, mag. Okay, BiPAP. Okay, so let's break this down. Okay, let's break down kind of what you guys are thinking. Okay, so a lot of you are thinking, hey, we should use mag sulfate. We should continue with the albuterol treatment and probably add Atrovent, which we probably did. Okay, we could turn up the CPAP, maybe even switch them to BiPAP. Okay, and then we could go epi. So lots of information to break down here. Okay, so let's talk about what our options are here. Okay, the solumedrol, your steroid, great choice. It should be used in this situation. I agree. Are you going to see a drastic change in your patient by using it? Likely not. Okay, likely not. So that's the first one. Continue with the albuterol and salbutamol or your ipratropium bromide. Totally agree. Continue to do that for sure. Okay, because we know the problem is in the bronchioles. Okay, and we know that salbutamol or albuterol and ipratropium bromide is going to directly impact those bronchioles. Okay, so yes, I agree. You can even attach your, I just want to show you the patient. And on the CPAP, you can even attach your nebulized medications to a CPAP device in order to get that medication even deeper in order to impact the small bronchioles. That's a possibility as well. So I think that that would be a route that I would go, being aggressive with this. Okay, so let's talk about mag sulfate. Mag sulfate in advanced respiratory failure, advanced respiratory distress, has shown to improve bronchodilation in order to improve respiratory movement and respiratory drive. Okay, so do I think mag sulfate is a good choice in this patient? Absolutely. Do I think it's a little late for this patient? Possibly. Okay, the evidence shows that mag sulfate has a better impact on respiratory failure in like advanced stages of respiratory failure as opposed to mild or moderate. So in a severe respiratory distress patient or respiratory failure patient, mag sulfate does show that it can make improvements. Okay, so would I probably go that route? Yes, I would. So that's the first, that's probably my biggest thing that I'm thinking to going. And then the last one that I want to touch on is your epinephrine. Okay, should you use epinephrine in this patient? Yeah, I think that this is probably a patient that you want to use epinephrine in. However, keep in mind that this patient is severely hypoxic. And what does epinephrine do as a side effect? It increases myocardial oxygen demand. Okay, so is epi probably warranted in this situation? Yes. However, it does come with risk. And so you have to weigh the benefits and the risk of using epi. Is this a patient that I probably would consider epi in? Yeah. Okay. But just keep in mind that no matter what medication you choose, there is a risk to using it. And epi is one of those that I think can be used in this situation. However, you need to be cautious of the fact that you might have negative cardiac effects because this patient is already hypoxic. Their heart is already hypoxic. And so we need to take that into consideration. Okay, so lots to take in from all of this. Now, the whole point of this is to really think about what treatments we could do in order to stave off intubation. And I think that it's possible you could get there, but you want to try and make the decision to intubate this patient earlier than later. And the reason being is that if you get this patient down into a situation where you're now doing a crash intubation because they're basically in arrest or peri-arrest, that's a very difficult intubation situation to be. This patient is going to be in a cardiac arrest due to hypoxia. And that is a difficult situation to reverse. Okay, so yes, absolutely use treatments that are going to reverse some of this effect. However, keep in mind that intubation should be closely in the back of your mind, because if things continue to deteriorate, this patient is going to get sick and go into arrest. Okay, so that's what I want to talk about next. Is we kind of talked about how intubation is going to be on the forefront of your mind, but my question to you would be, what are some things that you would be thinking about that give you the indication that you should consider intubation? What are some things that you're looking at in a patient that says, I need to intubate this patient? What are those key indicators? Because I think making a decision to intubate can be a difficult decision. Okay, it's probably one of the hardest things that we do is making a decision to intubate or not. So what are some things that you would be thinking about to indicate that you should intubate this patient? Go ahead, put them in the comments. What are you thinking? What are some things that you're looking at, go, this is something that I want to intubate. This is a patient that I need to intubate, or I'm going to lose this patient. Because you're going to have to make that decision. You're going to have to think that through. Lack of gag, protect airway. But what does that mean, Kim? Like, I agree that we want to protect the airway, but what does that mean exactly? Like, what are some things that are going, this patient's airway is compromised, I need to take it? And I know that you're an RT, so that's why I'm kind of asking, like, what are some things that you're looking at that go, I need to intubate that patient from an airway compromise standpoint? Pending respiratory failure, deteriorating respiratory mental status, increased EtCO2, decrease in SpO2, progressive fatigue, ineffective tidal volume, respiratory or cardiac arrest. That's a lot. That's a lot. And I agree with your entire assessment. What are some things that you're looking at are exactly those? I'm going to break those down in a more simple term in a sec here. I just want to see what else everyone else is thinking. Loss of consciousness, respiratory distress. In the UK, we can't just intubate. We have to ask for a specialist paramedic to attend separately. That's fine. So think of it this way. In the UK, where you're like, we can't intubate, we have to ask for someone. Okay, so what are some indications in that situation where I can't intubate, I don't know, and so we'd have to ask for a specialty paramedic or critical care transport, whatever the case may be. If you're not able to intubate, then change the question up to this. What signs are you looking for to tell you that you need to get a critical care transport or you need a specialized paramedic to intubate this patient? What are some signs that would indicate that for you? So just change the question a little bit, because making that decision is just as important. So what are some indications that you need to call in a specialist paramedic or critical care transport team to intubate this patient? There's a lot to unpack here, and we will in a sec. I just want you to kind of think of it in that way. Hemodynamic changes, signs of shock, cyanosis, SpO2 less than 70. I think that, yeah, let's break this down. Okay, so yeah, okay, so let's break this down. There's a lot to unpack here. There wasn't a whole lot of consistent answers here, so I want to kind of just take a step back and think about some of the decisions that you have to make and what you're looking for. When it comes to deciding to intubate, and this could be a class on itself, and we have done a 2-hour class on this that we had to break up into multiple parts, but I digress. So deciding to intubate is probably one of the most difficult decisions that you're going to do as a paramedic, is making the decision whether you're going to pull the trigger or not. Okay? Because when you make that decision, you're putting your patient at risk. Regardless of how good you are at intubating, there is always risks and there's always benefits. And your decision is going to be weighing those benefits compared to the risks. Okay? So that's the way that I like to think about an intubation, is that if I don't intubate, what is the risk of that? And if I do intubate, what is the risk of that? What's the benefit? And if I can justify the benefits outweigh the risk, then I intubate. Okay, so how do I make that decision of what's benefits and what's risks? Well, first off is that, how is my patient doing with my treatment right now? Are they getting better? If they're not getting better with mag sulfate, if they're not getting better with CPAP, if they're not getting better with increased oxygenation, from, say, putting a nasal cannula underneath a CPAP in order to increase your FiO2, are they getting better? If the answer is no, and I'm out of treatments outside of intubation, then the only option I have is to intubate. So that's something to think about there. Okay, so what I'm using to decide to intubate is what I have done. Have I exhausted any other treatment that I could do prior to intubation? Okay, have I exhausted everything I can do prior to intubation? If the answer is yes, and my patient is still not improving, intubation. Like that's the choice that I'm making in that decision, in that point. Okay, so that's the first thing, is that how my patient is doing inside the treatments that I've already done. And if they're not improving and I've exhausted all efforts, I need to look at intubating. I have to intubate in that situation. The next thing is looking at airway compromise. Okay, how is my patient managing their own airway? Okay, are they even benefiting from the CPAP? Are their respiratory efforts so weak that they're even ventilating themselves anymore? Okay, so are they so altered that they no longer can protect their own airway? If the answer is they're too altered and they can't protect their own airway, then I need to look at intubating this patient. Okay, so those are the big things that I'm looking at as far as deciding to intubate these types of patients. Again, I'm looking at risk versus reward, okay, risk versus benefit, and then I'm looking at identifying those benefits. Okay, what happens if I don't intubate this patient? What happens if I do intubate this patient? Okay, and if I can justify that the benefits are higher than the risks, then I have to seriously consider intubating this patient. Okay, that's how I go into my calls, okay, and my decision making. So it's very methodical thought process in order to do that, and that's how you need to think about it. These types of patients benefit from you anticipating where they're going. And you can anticipate where they're going by knowing what's actually going on inside their lungs. And that is knowing what COPD is all about. And so I want to look at knowing kind of what type of failure this patient is in as well. And that's where this patient is leading. Okay? Because we have two different types of respiratory failure. We have an oxygenation failure, and then we have a ventilation failure. Okay? Or what we call hypoxemic, okay, hypoxic failures and hypercapnic failures. So to distinguish between the two, in a hypoxic failure, these patients have an issue with the alveoli. So they have a thickening, they have an inability to move oxygen from here into the blood. Okay, they have an inability to do this. These types of patients are your pulmonary edema patients. These types of patients are your ARDS patients, your pneumonia patients, patients that have a clogging or thickening of the alveoli that doesn't allow for oxygen transport. That's a hypoxic failure patient. That's the cause of their failure. The hypercapnic failures are due to the inability to move air in and out of the alveoli. So your COPD patients, like this one, is a hypercapnic failure. Your patients that have respiratory fatigue are your hypercapnic failures. Your Kussmaul's respirations, your DKA patients that have Kussmaul respirations, those are respiratory failure patients due to hypercapnic problems because they have muscle failure. So that's what you're looking at in order to distinguish between the two. Does one lead to the other? So is our hypercapnic patient that's COPD origin leading to a hypoxic problem? Yes. But the origin of their problem was their ventilation issues, meaning that they were a hypercapnic problem. Now, why isn't the CPAP working in this patient would be another question that I would ask. And the answer is because of this issue, is that CPAP is a continuous movement of air that ultimately is going to improve pressures in the alveoli. Okay, so this patient, the CPAP can benefit if we use it early enough. But if we use it late enough and they have an advanced COPD issue, advanced ventilation issue, it really doesn't matter how much CPAP we use and increasing the pressure on the CPAP. It doesn't really matter because what CPAP's ultimately doing is getting more pressure in the alveoli. That's its job. So can it benefit these patients? Yes, if it's used early enough and they don't continue to deteriorate. But this is why COPD is not helping this patient, is because COPD is more dealing with this issue and less helping this issue. So that's why our COPD patient that has CPAP on is continuing to deteriorate, because ultimately we're not attacking the problem. That's what albuterol does. That's what magnesium does. That's what epi does. Those things cause bronchodilation. CPAP can cause a stenting of bronchioles, but ultimately their job is to actually get pressure in the alveoli. And that's ultimately not our problem. Okay, is it going to help the oxygenation issue? Yes. Is it going to help the ventilation issue? Not really. Okay, so be careful with that as well, and knowing the origins of this, and that's how you anticipate how these patients are going to do. So yes, CPAP is great for these patients, but there is a point in which it is no longer going to help. Okay, so let's talk about our final thing is that, we already talked about that. So we've decided to intubate this patient. Okay? We want to intubate this patient. However, looking at the vital signs, what should we do prior to intubation? Okay, could we just give the ketamine? Could we just give the rocuronium and then intubate this patient? What do you think would happen if we tried to do that? What do you think would happen if we just attempted to give ketamine, give rocuronium, and intubate this patient in this state? Remember, this is what our vital signs look like right now. What do you think would happen? Personally, I think that this patient would probably go into a hypoxic arrest if you attempted to just give ketamine and give rocuronium and intubate this patient right now. I think they would go into arrest for a couple reasons. One, ketamine may benefit the bronchodilation in this patient, but the fact that we have an oxygenation issue, we have a very severely hypoxic patient, then we're going to put them into an apneic state for an extended period of time during that intubation, this patient will likely drop their saturations into the 60s, maybe in 50s, and then arrest. Okay. On the other side of that is that also giving medications like rocuronium that are going to knock out sympathetic drive. And sympathetic drive sympathetic drive is also going to improve blood pressures, improve compensation in a time of shock. This patient has a heart rate of 144, but keep in mind that this blood pressure is a red flag. You might go, oh, this patient's not hypotensive, good. But think about it this way, is that in a blood pressure of 108 on 70, shouldn't you expect it to be higher if your heart rate's 144? So if you have a patient that has a heart rate of 144, you should expect that blood pressure to be higher. So this is kind of an ominous sign of, okay, this patient is not hypotensive, but taking in consideration this patient's heart rate is 144. They're sympathetically trying to compensate, and all they're able to muster is this. So when you take away that sympathetic drive, that heart rate, what do you think is going to happen to the blood pressure? It's going to go down. So you have two problems with this patient. That you need to deal with before intubating. And that is you have a blood pressure problem, and then you have an oxygenation problem. So let's talk about this blood pressure problem. So you could swap out norepi. I have norepi here, but you can swap out that with epi as well. So you want to resuscitate this patient by using a pressor that's going to improve preload in the heart. So that way when we create an apneic phase and using rocuronium and ketamine, that we don't have a significant drop in blood pressure because we knock out respiratory drive, we increase pulmonary pressures that ultimately create a cardiac output decrease. So we want to avoid those issues by compensating by using medications that can improve cardiac output. Things like norepi and epinephrine. So that would be the first thing, is how do we correct the blood pressure? By using things that are going to improve or increase blood pressure, like vasopressors, like norepinephrine and epinephrine. So that's the first thing. Now, let's look at the oxygenation issue. How could we improve or try and increase oxygenation in this patient prior to intubate? Because we know that if we try and intubate this patient in the state that they're in, they would likely go into a hypoxic arrest, or at least it would be likely. So how could we try and increase the SpO2 at least to like 90 or something resembling an acceptable SpO2 prior to intubation? What could we do? Go ahead and put that in the comments. What could we do to increase oxygenation? Bag them with O2, so using a BVM, increasing PEEP and CPAP. What else? Let's go look over here. What is in Instagram thinking? Okay, supraglottic airway. Okay. Nasal cannula under the CPAP. Pre-oxygenate with a bag, mask, and ventilation. PEEP and FiO2. Love it. Okay, that's actually where I was going to go. Okay. So what could you do to improve oxygenation? Well, you have really two options. Okay, I'm just going to use this slide just to kind of draw it out. So you have two ways of improving oxygenation. Either you can recruit more alveoli, so in other words, increase PEEP or positive and expiratory pressure, or inspiratory pressures. Okay, so you're improving alveolar recruitment. That's one way in order to improve oxygenation, is get better recruitment out of the alveoli. The second way to do that, to increase oxygenation, is increase the concentration by increasing FiO2. Those are your two options. Those are your two ways of improving oxygenation in a patient. So FiO2 is about increasing the concentrations of oxygen. So you already have CPAP on your patient. So maybe putting a nasal cannula underneath that mask and turning it up to 6 liters per minute and get even more oxygen concentrations into the alveoli. So that's maybe an option. Okay, I would probably be doing that in order to improve oxygenation. Okay? If my patient's respiratory drive is so poor, CPAP isn't really a benefit, then I would probably replace CPAP with using a BVM. Okay, and trying to use a BVM in order to drive respirations. So that would be, and then you could use a PEEP valve on that BVM in order to recruit more alveoli and get more respiratory drive out of that patient. So what am I going to do prior to intubating this patient? I'm probably going to increase the oxygen concentration, increase FiO2, and then I'm going to either turn up my CPAP because we've already taken care of the blood pressure, or I'm going to swap my CPAP out because my patient has poor respiratory drive with a BVM and try and ventilate this patient with a PEEP valve and increase alveolar recruitment that way. Those are really your two options at this point. Okay, so those are the two things you're going to do. Increase the blood pressure by using things like norepinephrine and epinephrine in order to resuscitate that blood pressure. The second thing that you're going to do is try and increase the oxygenation by swapping into with a BVM and a PEEP valve, as well as an FiO2, increasing the FiO2 and concentrate there. And then try and get the SpO2 as high as you can for as long as you can. So the idea is that you want to try and get the SpO2 at like 93% for, like 3 minutes kind of idea. Sometimes you just don't get there because you're just doing all of these things. The patient is continually deteriorating. So if you get that SpO2 to as high as you possibly can prior to intubation, that is the goal. And that will give you some time in order to intubate this patient prior to crash during that apneic phase. And making sure that we have constant oxygen concentration while we're doing the intubation is also going to be a benefit to this patient too. So that is what we're going to do prior to intubating this patient. And we're probably going to use ketamine and rock, or maybe just ketamine and do a delayed sequence intubation. Those are things that we can talk about at a later date. But ketamine is probably going to be your choice in this patient because it has bronchodilatory effects that are going to be a benefit to this patient as well. Okay. Any questions with what we've covered today? Go ahead and put that in the comments. Any questions that you have? How many times would you ventilate with BVM if you replace CPAP? 10 to 12? Yeah, so it's a good question. How many times would I ventilate this patient? Remember, this patient still has respiratory drive. They're still trying to take a breath, and we saw that. They're still trying to take breaths of around 18 breaths per minute. That's probably a little high, but I would try and use their respiratory drive and assist with the BVM. Because if you try and force a breath into them, that doesn't really work. So in a patient that is conscious, or at least in a semi-conscious state like we have here, you're not really going to be able to force respirations with BVM. It doesn't work. So you're probably going to be trying to drive their respiratory effort with the breath that they're triggering themselves. Effectively trying to be a ventilator where they're controlling the respiratory drive. You're using a BVM in order to do that. Okay, so you're going to be more trying to match their ventilation rate and using a BVM in order to bring in more volume per breath. So ideally, yeah, you want to use that BVM at 10 to 12, but in a semi-conscious state, you can't force respirations in a patient. So you're going to have to try and match the respiratory rate and just assist them with volume. What is the recommended PEEP level after intubation? That as far as PEEP after intubation, as far as I'm concerned, what I'm looking at is their oxygenation status. So after the intubation is done and I am ventilating the patient now, and I have good EtCO2 waveform, I know that I have good airway capture, then I'm going to use my SpO2 in order to guide the amount of PEEP. In this particular patient, I would start at 5 centimeters of water a PEEP, and then I would use my SpO2 in order to guide whether I need more or not. If I start to see that my SpO2 is going up, then I would probably stay at 5. If I'm noticing that my SpO2 is not rising, despite using other medications like albuterol, getting the MDIs down the tube, all those kind of things, or other medication options, those kind of things, if I'm noticing that they're still not working and my SpO2 is so low, then yes, that's going to increase my PEEP. So those are the kind of things that I'm going to use in order to determine that. That being said, again, our problem isn't alveolar, it is bronchial. And so even though this patient is intubated, yes, we want to use PEEP sometimes, but our big problem and what we still want to target is bronchodilation. Okay, let's see if there's any other questions. If the patient is too anxious for interventions, would you recommend sedation right away in order to assist ventilations and oxygenation? That's a great question. If my patient is anxious and panicking and altered, keep in mind that it's all due to the hypoxic state that they're in. So you may be able to correct that by increasing the oxygenation status of your patient. But if they're super anxious, they're panicking, I would probably consider using ketamine earlier than later and do more of a delayed sequence intubation. Again, we do not have time to cover that today, but that's probably the route that I would go if it's even in your protocol to do it. Again, you have to follow your protocols in this state, in this situation. But in a state like that where they're agitated, they're confused, they're not compliant with treatments, then you kind of have to go down the route of how can I control this situation again and help this patient? And the answer is probably ketamine earlier, so that way we can start to bring them back into a state that we can control. But like I said, that is something that usually is not in protocols. But if you had free reign and you were allowed to, that would probably be the route that you would want to go, is ketamine earlier rather than later. COPD is chronic obstructive pulmonary disease. How often do you do lives? I do them every Friday. So what about switching to CPAP or BiPAP instead of CPAP? It's a fantastic question. So BiPAP in itself, what it's going to do is that it's going to change the pressures based on inspiratory triggers and expiratory triggers. So instead of continuous, which CPAP is just basically a constant rush of air that's being forced into the alveoli, what BiPAP does is that during inspiration, it's going to increase pressure into the lungs. With expiration, it's going to decrease the pressure, so that way we don't have to breathe against all that forced air. Would BiPAP be a benefit to this patient as opposed to CPAP? Possibly. Yes, I think that is a definite possibility because BiPAP has more of an impact on ventilation and helping ventilation problems and hypercapnic problems like we saw with this patient, as opposed to oxygenation problems, which CPAP has kind of the benefit there. So do I think BiPAP is a good option for this patient? Yes. The reason I didn't bring it up in this class is because BiPAP is usually not an option in North American EMS. And so I chose not to bring it up because it's not used very often in EMS. But if you do have the option to choose between BiPAP and CPAP, BiPAP would probably be a better choice in this patient than CPAP. Is this live recorded? It is, and then turned into an interactive scenario that we use for continuing education on our site. So if you want to check it out and get continuing education credits for this, then you can absolutely become a member and get that. To raise the BP, why would you administer vasopressors before fluids? That's a good question. So why am I using vasopressors as opposed to fluids in order to increase the blood pressure in this patient? It's a good question. My answer to that is that this patient is likely not fluid depleted. There's nothing to indicate that this patient is fluid depleted. And we know that giving fluids in a patient that doesn't require them has minimal to no impact. So that's my thought process with this patient, is that does this patient require fluids? Is there any reason to suggest that this patient is fluid depleted? And I think the answer in this particular case with the COPD patient, there's nothing pathological to state or suggest that they are fluid depleted. So could you use fluids in this patient? Sure. You could use small amounts of fluid to increase this patient's compartment. But I think that when we're looking at intubating a patient, we want something that's going to be more consistent and something that's going to be more reliant and dependent, and that is a continuous vasopressor introduction as opposed to just fluids. Because fluids are inconsistent at best in increasing cardiac output, increasing blood pressure. But we know that if we use something like norepi or epinephrine in order to increase blood pressure, we know the effect of that. And we know we're going to get it. So that would be my way of thinking about it. Is it why I'm not using fluids? Because one, they don't require fluids, likely don't require fluids. They're probably not fluid depleted. And two is that I want a consistent, dependable increase in blood pressure, and I can do that through pharmacology better than I can do that with fluids. That's my thought process with it. Would you do push dose pressors before setting up vasopressor on the pump? If you have the option to start a vasopressor drip or a levofed drip or epinephrine drip, if you have the option to do that, then just do it. Because if you can do that, it takes almost just as much time to do that than it does to create a push dose epinephrine, especially if you're using TIE Fighter and all that kind of stuff. It's just as quick to set up a drip. So if you have it in your protocol to set up a drip, and you're choosing between using a push dose presser and using an infusion, I would just do the infusion and save yourself some time. Because you're going to be doing a push dose presser, use that during the intubation phase, and then you're going to switch to your infusion after that case. That just kind of seems like you're doing two redundant things. And so in my opinion, what I typically do is that I would probably start an epi drip, especially if I was short of hands, and start the epi drip as opposed to doing both. But that's just my opinion. It doesn't have to be the right way or the wrong way. It's just the way that I typically do things, because I'm trying to save time and not do redundant things. But again, my ability to do that is different than your ability to do that. So it would be more of your decision of what you feel is best for your patient. I've done it both ways. That's just the way I do it now. Tips for drug profile studying. You know what? I would say that the best way to study medications in paramedic school is to understand how they work in the body. So really focus on the class of medications. So take your class of medications and put all the drugs that are in your profile under what class they stand in. Okay. So for example, just take a medication, for example, Ativan and lorazepam and Valium all fall under benzodiazepines. And so you take all those medications, you put them under the class card of benzodiazepines. And then you learn how benzodiazepines work in the body by inhibiting GABA. Or, you know what I mean. So you are basically going to be focusing on, the idea with that is that you're taking 3 drugs that you're supposed to learn, and instead of learning them individually and how they work, you're going to learn them all together at the same time by studying the class of medications. That would be my advice to start with, is that organize your medications in classes of drugs and then study the class and how they work. So that way you're not trying to study 900 things individually. You group them into 9 different groups. Does that make sense? That's where I would start. Am I a Master Chief? No, just a flight paramedic. Be pretty sweet for the Master Chief, though. So thanks again for joining me today. I think I'll leave it there for you guys to kind of muster on this. And if you do have any more questions, please feel free to reach out. More than happy to chat. We are finishing the end of our airway month, and we're getting into psychological emergencies starting in October. So hopefully you guys are excited for that. So we're going to be making a transition to there. If you do have questions for us and you want to see different videos, please feel free to reach out to us. More than happy to chat and take your suggestions on things that you're struggling with when it comes to psychological emergencies. And we will talk to you guys next time. So thanks again for joining me, and see you on the next live. Bye for now. Nicholas, if you're taking the COPR exam, you should definitely check out our live COPR prep. If you haven't already, it's in our link in our bio. So check that out. And we have a 93% success rate on the COPR exam for students that take our COPR prep. Definitely check that out. No problem. Have a good one. Take care, everyone.